Medurstand. Understanding Medicine.
I am Professor Aziz-ur-Rehman, and I hope you have watched my earlier videos on different thyroid disorders. I had 4 lectures actually. One was on, the 2 were on hypothyroidism and two were on hyperthyroidism. Now is the time to revise what we learned from those 2 lectures and also have little quiz. So I just hope that you will like this activity. Now we're going to proceed with the questions as my routine in the previous quizzes. I will display the question and give a pause of few seconds, approximately 5 to 10 seconds, for you to ponder and come up with the answer. Of course, there will be no active interaction because of this recorded video, but you can assess yourself if your answer is correct. After that, I will display the correct answer, and if required, we will have some discussion also. As I always say, this is not actually a test, this is a kind of revision in the form of a quiz. So if you are able to give correct answers, that should give you a great feeling. And if you are unable to come up with correct answers, that should also shake you up a bit, that to learn more. So let's start. So the first question is regarding hypothyroidism. Which one of the following is typical sign related to deep tendon reflexes? Hyporeflexia, slow relaxation, or absent reflexes? Which one is the typical of hypothyroidism when it is advanced? Slow relaxation, also called Wortmann sign. Now, of course, I understand in advanced diseases, reflexes may become absent, but I can't imagine any situation in hypothyroidism where there would be hyperreflexia unless there is some other neurological condition. So typical neurological sign in advanced hypothyroidism is slow relaxation of deep tendon reflexes. Typically we elicit it on ankle jerk, and actually you can record it and show the relaxation is slow. This is called photomotogram. So this is actually very typical, although not very sensitive. So once you see this sign in the proper context, you should be sure that this patient has hypothyroidism. But it is possible to have milder form of hypothyroidism where this ankle jerk is normal, knee jerk is normal. Next, let's proceed to the next question now. In primary hypothyroidism, and I'm sure you know what is primary hypothyroidism, when the problem is the thyroid gland itself, which one of the following is most sensitive lab test? Meaning that which one will become abnormal first of all? Reduced free T4, abbreviated as FT4, reduced T3, reduced TSH, or elevated TSH. We're talking about primary hypothyroidism and we're looking for a most sensitive test. Which one do you think is the correct answer? If you have attended my lecture, you should have no difficulty answering this one. Yes, it is elevated TSH. If you remember, I made a picture of that seesaw with the fulcrum on one side, TSH arm longer than FT4 arm. So even slight reduction in FT4 would lead to marked elevation in TSH. That means there would be a situation where FT4 may be within normal range, but TSH has elevated to an abnormal level. So that makes TSH a very, very sensitive test. So if the suspicion of hypothyroidism low, you can just have TSH, and if it is normal, you just rule out primary hypothyroidism. Okay, let's move on to the next one. Regarding thyroxine replacement therapy, which of the following statement is not true? All right, it's not true. Total dose is administered once daily. It is best taken on empty stomach, and it may be discontinued once T3, T4, TSHs are all within normal range. That means once patient becomes euthyroid, then thyroxine may be discontinued. Which one is not true? This one is not true. In fact, we have to emphasize to the patient that this is a almost lifelong medication, especially if the patient has presented with myxedema. Myxedema is an advanced form of hypothyroidism. The fact that somebody has developed myxedema means that hypothyroidism is really, really advanced and irreversible. So treatment would be lifelong. If T3, T4, TSH are all within normal limits, that means you have achieved a euthyroid state. No further adjustment in dosing is needed, and patient may continue. Of course, during stresses, during operation, during some other condition, you might have to revise thyroxine treatment, but mostly the same dosage should continue for indefinite period of time. Move on to the next one. Which one of the following is not a feature of hyperthyroidism due to Graves' disease? If you remember, hyperthyroidism may be due to Graves' disease, may be due to toxic adenoma. A transient hyperthyroidism may occur due to thyroiditis, or sometimes a nodule may start functioning, producing thyroxine in multinodular goiter also. So various types, but we are talking about Graves' disease now. What are the features? Diffuse enlargement of the thyroid is not, okay? So you're looking for the feature which is not that of Graves' disease. So diffuse enlargement of thyroid gland, thyroid bruit, increased radioactive iodine uptake, pre-tibial myxedema, large asymmetric goiter. Which one is not a feature of Graves' disease? It's easy, right? Isn't it? Large asymmetric goiter. In the Graves' disease, thyroid is usually enlarged, but it is diffusely enlarged. It is very symmetrical. By symmetrical, I means the normal thyroid shape. The normal thyroid itself is not exactly very geometrically symmetrical. It has got though the both lobes may be slightly different sizes. So whatever the shape of the thyroid is, that will be bigger. There will be no asymmetry, and thyroid is never very big. Okay, so that is the feature of Graves' disease. This one, so large asymmetric goiter would suggest multinodular toxic goiter. Okay, which of the following laboratory abnormality is compatible with hyperthyroidism? Right? So normal T3, normal T4 and normal TSH. All three are normal. Is it possible to have hyperthyroidism with all three key laboratory abnormalities within normal range? High T3, normal T4 and low TSH. So thyroxine is actually T4, that is normal, but T3 is high and TSH is slightly reduced. And third possibility is high T3, normal T4 and normal TSH. Which one you think is most compatible with the diagnosis of hyperthyroidism? None is actually very typical, because in typical case we expect T3, T4 both to be elevated and TSH to be reduced. This is a relatively atypical case, but which of the three is, in your opinion, compatible with the diagnosis of hyperthyroidism? High T3, normal T4 and low TSH. Now there is a condition called T3 toxicosis that actually refers to this condition where only T3 is elevated, T4 may be normal. So you may be confronted with the situation. The patient has symptoms suggestive of Graves' disease, but T4 may be normal, but T3 is high. When T3 is high, T3 will obviously suppress TSH because T3 has inhibitory effect on pituitary gland. It suppresses production of TSH, so TSH will be low. So out of the three, this one is compatible with the diagnosis of hyperthyroidism due to Graves' disease. This would be relatively a mild case, and I think if not treated, this patient would progress to frank hyperthyroidism. To my understanding, this T3 toxicosis is not an entity in itself. It is just a phase of hyperthyroidism. If not treated, this would typically progress to classical Graves' disease, where T3 and T4 both will be elevated. Now let's take up the next question. A young patient with primary hypothyroidism receiving thyroxine replacement therapy comes for a follow-up. In which of the situations you would not make any alteration in her current dosage? A case of primary hypothyroidism, already receiving thyroxine, has come for a follow-up. Now you just have to go through this laboratory test and see if further adjustment is needed. And you would of course not make any adjustment if, in your opinion, patient has already achieved the ideal goal. So the three situations are FT4 in lower normal range and TSH in upper normal range. So both are within the normal range, but FT4 is in the lower normal and TSH is in upper normal. Second situation, FT4 in upper normal range and TSH below normal range. This means less than normal. The third one is FT4 in upper normal range and TSH in lower normal range. I think there may be some confusion, but the wording is very clear. If I give you some seconds, you should read this again and see which one, in your opinion, is the best euthyroid state. If I'm treating this patient, I would like to achieve this one, FT4 in the upper normal range and TSH in the lower normal range. That means patient is euthyroid but in the slightly upper side. So I think it is best to keep patient slightly on the higher side within the normal physiological range. This one, first one, FT4 in lower normal range and a TSH in upper normal range, this is acceptable in those patients who have this coronary artery disease and are elderly. This one, where patient has a TSH is below normal range, I think this is perhaps not a TSH below normal. This probably means that patient is getting little excessive thyroxine. So I think this one is the best. All right, but all are perhaps acceptable, but this one is perhaps the best. All right, you are becoming expert now. In secondary hypothyroidism, secondary hypothyroidism, when there is a disease in the pituitary gland, which one of the following is considered to be the best therapeutic approach? Start with the thyroxine. Add hydrocortisone after patient becomes euthyroid. Start both thyroxine and hydrocortisone replacement simultaneously in full dose. Start physiological dose of hydrocortisone and add thyroxine after 1 week. Because it is a secondary hypothyroidism, this patient would need thyroxine and hydrocortisone both. So you just have to pick up the best strategy of the three. If you have attended my lecture on thyroxine replacement, I think it should be easy. Even otherwise, if you have read this topic elsewhere, you should be able to answer. Now let me display the correct answer. Start physiological dose of hydrocortisone. We don't really know how much cortisone this patient would need. We assume that patient is not producing any hydrocortisone. So we'll give the replacement dose, the physiological dose, which is equivalent to 20 or maybe 30 milligram of hydrocortisone. Or other steroids, the dosage will be different, equivalent dose of other steroid, but best is hydrocortisone. So to start with hydrocortisone, thyroxine can wait. Thyroxine should wait. Why? Because if you start thyroxine, especially if you start thyroxine before hydrocortisone, this is going to increase relative deficiency of cortisone and patient may actually go into Addisonian crisis. So it is the recommended approach that if you have to replace both thyroxine and hydrocortisone, start with hydrocortisone, give a physiological dose, which is 20 to 30 milligram of hydrocortisone divided into two doses, 2/3 administered in the morning, 1/3 in the afternoon, late afternoon, and after a week, without measuring hydrocortisone, you add thyroxine, and then you escalate thyroxine as we normally do till you get this euthyroid state. Right? Regarding radioactive iodine ablation, which of the following statement is untrue? Radioactive iodine ablation is great way of treating Graves' disease and other hyperthyroid states, but people have a lot of reservation. Many physicians also have a lot of reservations. I am very fond of this treatment because this is almost, of course, not the first line treatment, it's a second line treatment. But which of the following statement is untrue? Okay, right. It is contraindicated in childbearing age. It usually causes complete hypothyroidism and requires lifelong thyroxine replacement therapy thereafter. Of course, if somebody develops complete hypothyroidism, if there's complete destruction of thyroid gland by radioactive iodine, then patient would need thyroxine for life. It takes approximately 2 months to have its full effect. So once radioactive iodine is administered today, it will take approximately 2 months before you can say that patient has now come to the euthyroid state, and during this 2 months you have to sometime give anti-thyroid drugs. Which one is untrue? It is contraindicated in childbearing age. This is absolutely untrue. But that I do not mean that it can be taken during pregnancy. No, not at all. In patients with hyperthyroidism, pregnancy should be planned if patient desires to have a pregnancy. Then I think if radioactive iodine is given, patient just have to adopt some contraception, usually double contraception. Like for example, in a couple, the lady takes contraceptive pills and the male partner wears condom during intercourse. So double, just to make sure that pregnancy doesn't occur. After a radioactive iodine ablation, it is recommended that patient should not conceive, either male or female, should not conceive for at least 3 months. But I give another 3 months because I think it is never urgency to conceive, so one can wait for another 3 months. So after 6 months, it is absolutely safe to conceive. So this is a myth that radioactive iodine is contraindicated in childbearing age. It is certainly not recommended if there is a pregnancy or if pregnancy is likely. You have to plan pregnancy, but once radioactive iodine is given and 6 months later one can conceive without any risk of hazard. Right? In which of the following situations FNAC, which is fine needle aspiration biopsy cytology, is most strongly indicated? It may be indicated in more than one situation, but in which of the following 4 situations you think that FNAC is very strongly required? A woman with multiple colloid nodules, a woman with single hot nodule, hot means which is producing too much thyroxine, and this patient is likely to be hyperthyroid. A man with single solid nodule that is taking up iodine, that means again hot nodule. A man with single solid tumor that is not taking up iodine at all, cold nodule in a male. in a male patient, cold nodule which is solid. Which one is, I think definitely FNAC should be done? My answer would be a man with single solid tumor that is cold, that is not taking up radio, this is non-functional. So the chances of malignancy in this situation are the highest, approximately 25%. Of course, you do not want to miss. This patient may be asymptomatic. Patient just may have just noticed little nodule. Somebody else might have just noticed that little nodule. Patient may not have any symptoms, but if on ultrasound this tumor is solid and on radioactive iodine scan, if this tumor is not taking up, if this mass nodule is not taking up radioactive iodine, that is classified as a solid nodule, a cold nodule, I think biopsy must be done. If ultrasound shows a cyst, a cold cyst, then biopsy is perhaps not needed. In some cold nodules also, in the colloid nodule also, if there is some mass arising from one side, people want to do biopsy. That is also, I think, recommended. But a solid tumor, solid nodule which is cold, must be biopsied. Unless the patient and the surgeon, they decide to go for surgery straight away, that would be, I think, another opinion. But biopsy, it should be done, and then it should be decided if the surgery is needed. Surgery would of course mean most probably thyroidectomy, not just the removal of nodule. But I'm not an expert on that, but my guess is that thyroidectomy should be the answer. A woman comes with a large multinodular non-toxic goiter. What would you recommend as the first line of treatment? Okay, is somebody, some lady, you must have seen some women in our country with big thyroid glands with asymmetrical nodular goiter but without any symptoms. So which one you think is the ideal treatment? It is generally assumed to be due to chronic iodine deficiency. Okay, so iodine replacement, is that the first line treatment, or straight away surgery, or thyroxine replacement? Maybe if you give thyroxine, then thyroid gland will be offloaded, and by thyroxine you would suppress TSH and stimulation for thyroid growth may be minimized. Maybe that lead to regression of thyroid gland, or wait and see, or surgery as per patient preference. So out of 4 options, which one do you think is the best? I think one can have different opinion here. If this patient goes to a surgeon, the surgeon would definitely recommend surgery straight away. Iodine replacement, thyroxine replacement are certainly not going to work. Patient would need thyroxine replacement if this thyroid is removed surgically. I think wait and see or surgery as per patient preference. This is the best answer because it's not malignant. Surgery is not absolutely essential. It is patient preference. Some women, I have seen many people, many women who have this big nodular goiter, but they don't mind at all. Cosmetically, it is not disturbing. Mechanically, it is not causing dysphagia. It is not causing any difficulty in breathing, and they are just okay with this. So I think you can just wait and see until this patient develops some mechanical symptoms. So in my opinion, this last approach is the best one. But of course, it would vary patient to patient. Thank you very much. So this was a brief quiz. I just hope that you enjoyed it. And this is Professor Aziz-ur-Rehman from Medurstand, and I'm going to come with another series very shortly. Thank you very much for joining me, and please remain tuned, and I'm coming up with some other series of lectures. Thank you very much.